In this episode of the ASC Podcast with John Goehle, we cover the latest updates from the ASC industry, including an update on the Corporate Transparency Act, or CTA, a survey about Gen Z workers, a review of the requirements of RN Administered conscious sedation, and in our focus segment, we discuss smoke evacuation with Penny Smalley.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. We would like to thank our sponsors, Surgical Information Systems, providing cutting-edge information solutions for surgery providers, RFX Solutions, your all-in-one healthcare regulatory compliance software, MedServe, which is the only digital narcotic cabinet specifically designed and priced for surgery centers, helping standardize processes, compliance, eliminate paper logs, and prevent drug diversion, and Ambulatory Healthcare Strategies, the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, please visit our website at ascpodcast.com.
Welcome to episode 239 of the ASC Podcast with John Goehle, recorded on February 25th, 2025, from our studios in Spencerport, New York. I'm Sue Cronkite, your co-host and operations manager at Ambulatory Healthcare Strategies. As a reminder, the regulatory landscape for ASCs is constantly changing. The content in this episode reflects the most current information available at the time of recording. We encourage all ASCs to remain vigilant and keep up with any updates or new guidelines released by relevant regulatory authorities. Joining me today is John Goehle, the owner of Ambulatory Healthcare Strategies and one of the leading experts in the ambulatory surgery field. With over 3 decades of experience, John has authored more than 10 books on the ASC industry, and he is a highly regarded speaker on topics related to regulation, accreditation, and finance management.
So people have probably noticed that we haven't been recording for a bit. We have some great news, and we kind of mentioned it a little bit earlier, but our mascot, Rosie, the English Cream Golden Retriever, had 9 beautiful puppies on Super Bowl Sunday, and we've been kind of busy with that. So she's doing great. The puppies are doing great, and we're having a lot of fun. Yep. As we're recording this, their eyes are open. They're starting to crawl around already, and they're only 2.5 weeks old. So yes. We're in for a lot a lot of trouble in the next couple months here.
Yeah, and they've doubled or tripled in size. They are just growing like crazy.
Yeah, and it's so much fun. It really is a great joy to have them around, as well as being a great joy when they eventually go to their forever homes. So.
Especially for Rosie. Yeah. She's very happy to wave goodbye.
That's right. And speaking of that, it's been very snowy up in the Northeast here. We have at least, I'm on the ground, probably, a foot, 2 feet of snow. Yeah. And it's only down there because it melts and then
And we've had so much ice, too. And the icicles hanging from the house, they're probably 6 feet long, some of them. So
yeah, and
a lot
of
ice and snow.
Yeah, and I know that's causing quite a bit of problems for many of the surgery centers. Damage, of course, on the roof, water damage. We already talked about that in the last episode, so it's still continuing right now. So one thing to remember when you are impacted by anything, any type of weather event, especially cold weather or in particular cold weather, write those up as an incident report if you had to take any actions as part of the response to it. And if you had to do something like cancel cases or delay cases, those could be drills also.
And then you can talk through and see what you could have done better and really learn from it.
Yeah, and we generally allow about one drill per year to have been an actual event. So definitely something to think about. And also remember to revise your hazard vulnerability analysis if you haven't, to address any of the issues that you've had or any weather-related event. Sue, I've been following the Quality, Safety, and Oversight Memorandum from the Centers for Medicare and Medicaid Services, or CMS, and I don't see any updates to either the State Operations Manual or those memoranda. So we're going to keep a very close eye on that. We do expect some changes to occur. Probably need to give the new administration a couple months to get into things, but I do expect some major, changes to occur. But perhaps they won't happen, quickly in the ambulatory surgery area. So just so that you know, we are keeping a very close eye on that. Sue, why don't you talk about some of the most recent news?
So the FDA approved a new non-opioid analgesic for treating moderate to severe pain in adults. I'm not sure how to pronounce it. Journevax, I believe, or suzetrigine, reduces pain by targeting a pain signaling pathway that involves sodium channels in the peripheral nervous system to stop the pain signal from actually getting to the brain. So it's the first of this new class of pain medications to be approved. And in clinical trials on patients there were two different clinical trials. One, they had undergone abdominoplasty, and the other one where they had a bunionectomy. It was found to work as well as Vicodin. It was not tested against stronger opioids like morphine or oxycodone, though, and it's not meant for long-term use or chronic pain. But it's a good option for people that are trying to reduce, the use of opioids.
And it seems like it's particularly well suited for the ambulatory surgery industry and the ambulatory surgery center. So more to come on that, I'm sure. But do keep an eye out. We don't know how to pronounce it, but it is Journavx is the brand name, and then suzetrigine.
I think suzetrigine looks like Suzetrigine.
So I'll look it up.
And that's the first of the new class, like I said, but it looks like they're working on other ones too. So I think, there's a lot of push out there to try to find other options.
And especially with the opioid epidemic that we are experiencing right now, this is extremely important, I think.
And the good thing about it, although it blocks the pain pathway, which is something that, you can get with other medications, but it doesn't give you any of that euphoria that is the thing that really grabs people that, end up with addiction issues. And the beneficial ownership reporting requirements are back in effect. The new deadline is March 21st, 2025. John will explain a little bit about it. We don't really know if it's going to stay in effect, and this isn't really a regulatory thing, so it's not something we know as much about, but you can find more information on the U.S. Treasury Financial Crimes Enforcement Network. There's a frequently asked questions section, and we've got two links. The frequently asked question we'll put in the show notes, and they also have a small entity compliance guide that we'll put that link in the show notes.
So you might remember this is also known as the Corporate Transparency Act, and we've referred to it several times. I've gotten so confused. I think we said it was on, then we told it was off. And as we record this on February 25th, it is back on again, and it would be due March 21st, 2025. Now, this is a disclosure that requires you to provide personal information for all of your owners of your LLC or Subchapter S corporation, basically small businesses. And I would try to avoid this as much as possible because, of course, you're providing the government with information or personal information about your ownership interests. And I'm sure your owners probably aren't terribly excited about having that information uploaded to the government unless we absolutely have to. So my personal opinion is that we might want to wait to as close to March 21st, 2025 to actually file it to Sue's point, to see if it remains in effect, since it's been put off and then put back on again several times. And we are hoping that the administration will look at this as an undue burden on our small businesses and put it to bed permanently. I do believe it would require congressional action to do that, but I believe that the administration could at least hold it off until Congress can take an action on it. And again, not to be political at all on this thing, it is one of those things that does require reporting that, I think most of our small businesses would prefer not to do if we can avoid it at all. And again, quite a burden. Now, Sue mentioned that this is not a healthcare regulatory burden, so that's not something we tend to talk about on the podcast, but it has been showing up quite a bit on small business newsletters. And I actually read a pretty in-depth article at the United States Chamber of Commerce website. We are a member of that, and some of the information we're providing here comes from that. But as Sue indicated, we're going to provide some links to some resources for this, And again, talk to your owners. This should be something that would be documented in your governing body minutes as to whatever actions you take, and find out from them if they wish to report this at this time or wait a little bit longer.
So I was hesitant to put in this next one, but we talked a lot about mentoring and succession planning and the challenges of different generations working together. So there was a couple of articles about Gen Z workers, and I just wanted to make the point that I'm sure every new generation, there's always been issues with earlier generations. We all grow up in a different time and all of that. So I don't mean to pick on Gen Z workers, but I think it's something we've heard a lot about, people, talking about it, and hey, how do you, mix the generations and not have that stress occur. So I thought I'd throw this in there. So
yeah. And so that's a very good point, though, is that every generation has their quirks, strengths and weaknesses, or things that you need to address if you want to be a good employer. And that's what this is really all about, is how do we best supervise people in these different generations so that we don't lose them. I mean, that's what's happening, is we're having a lot of turnover, and we're having problems figuring out exactly what level of training we need to give to these employees. So go ahead.
So in Intelligent.com, there were 2 articles about Gen Z workers. For the first one, they interviewed 1,000 U.S. managers who oversee Gen Z employees. Here are some of their findings. 75% said this age group required more time and resources than they were used to having to provide. 18% of the managers considered quitting due to the stress of managing the Gen Z workers. And they mentioned some of the issues were excessive phone use and poor work ethic. Now, the article noted that some of these issues may stem from unrealistic expectations. For many new grads, while they might excel at technology, they might struggle with skills like communication, time management, and teamwork, which has probably always been the case until you're out there in the workforce.
Right.
And especially now, people that have gone to school during the pandemic time, they might have missed out on internships and other, in-person kind of learning opportunities. So they might just need a bit more time to really, pick up on those more soft skills.
And so we should point out that you mentioned that that as part of the survey they mentioned excessive phone use. I'm assuming that they're referring to
probably texting, social media,
right, as opposed to actually talking on the phone, because that's I think one thing that that comes out of this conversation that you had with regard to communication, that they're often have real challenges or with calling people on the phone as opposed to texting.
And for the second article, 966 business leaders were surveyed about their hiring decisions and their thoughts about recent college graduates. So 9 in 10 hiring managers said recent college grads should undergo etiquette training. 94% of companies report hiring recent college graduates, and among these companies, only 25% stated that all recent college graduate hires worked out well. 62% mentioned that only some were successful, and 14% report that only a few or none of the hires were successful. The reasons that they gave for the new hires not working out were 50% mentioned lack of motivation or initiative, 39% were due to poor communication skills and a lack of professionalism, which was 46%. And other factors included struggles with feedback and inadequate problem-solving abilities.
So I think this really gets down to training your staff members, the existing staff members, on how to interrelate with these new college grads, providing the new college grads with training to help them to be more successful. I think, and I kind of I think it goes without saying, patience in working with them. Not giving up. I personally feel you really shouldn't be giving up too soon on them. But I think that, of course, we're in a very ASCs are a very fast-paced environment, and a lot of people, have a hard time taking the time to do this. Yeah. I guess one way I would try to approach that is, before you put them in front of people who might not have that patience, make sure you provide that training, that mentoring, so that they're well prepared for it. And we know that that's not always easy. That we're in a rush to do this, and we don't always have the time to take that time. And
it can go both ways. It's important to note the strengths of each generation and try to encourage some cross-communication and mentoring on both sides. Maybe some other generations are having problems with technology.
Yeah.
And then the newer grads might be having a little problem with phone use or with, time management or something like that. So kind of, maybe partner up different people and have them learn from each other. So it's not all, critical on the newer generation.
Yeah, and Sue, I think that's a good point too. One thing that is important to remember is we need to be very careful about avoiding stereotypes here. It's easy to talk about what the statistics show, but not everybody's going to fall into that. We certainly, in our company, work with a lot of Gen Z people that don't exhibit these characteristics here. So please, that's extremely important too, is not to pigeonhole people, not to immediately jump to a conclusion based upon these studies that come out here. Give them a chance, and then obviously really work hard in providing them skills they're going to need, because we don't really have much choice. I mean, we're going to have to to bring these workers into our place, and we had to find a way to make them successful.
And maybe, like you had said about training programs, so they could help create a training program for technology, and then other people could present some training programs on communication styles and that kind of thing. Just don't. I think when you're used to one thing and something different comes along, you only see the negative side of it. But there's a lot of positive too, and the more variety I think that you have in your staff, the stronger it can be if you just learn to work with it.
And by the way, we have recognized this at a state association level as a skill that we need to work on. In other words, some training that we need to work on. So we're trying to put together, we're working the very beginning stages, some type of a virtual conference on it, or we might include it with our multi-state conference in November of 2025 coming up.
So ASCQuality.org, which I feel like I've talked about a lot lately. They're coming up with a lot of new tools and information. So they have a new safety and quality assessment tool. It's free, and it takes about 20 minutes to complete once you make sure you've gathered all the information that you need. The current submission period ends March 15th. I'm assuming it's something they're going to continue to repeat. So first, I'll just give you a quick rundown. The information you would need are your CMS certification number, your NPI, the year that your ASC opened, the most recent calendar year, annual case volume, and date of accreditation expiration, date of last patient safety culture survey, if applicable, and the date of the last employee satisfaction survey, if it's applicable. So you can use this for benchmarking, can provide a tool to promote ASCs, like it'll give you some good information about what you're doing right, to share with patients, payers, employers, and your community, can foster performance improvement, and just promotes the whole ASC value story is kind of how they put that. So it's just a tool to use if you want to, and you just go to the ASCQuality.org and you can put in the information and believe you get kind of a report from that. And they also have more tools that you can use to improve any of the issues you need to.
And if you haven't, and we'll provide a link to this tool, but spend some time at the ASCQuality.org website. It's been incredible what they have updated. To your point, Sue, we probably can do an entire episode on, which we're practically doing, on the different tools that are available there. And so definitely spend some time up there. This will really help you with your accreditation to try to, especially, and we've talked about how ASCQuality.org does, provide you a lot of benchmarking tools, external benchmarking tools that you can use to meet your benchmarking requirements from your accreditation organization. And again, we've been using ASCQuality.org for years within our company with our clients, and never really had a problem with passing the accreditation surveys merely by using that. Sometimes we encourage people to use other tools out there too, but if you can't afford it, here's a free tool. That's another thing we need to point out. This is free, totally free. The website is totally free to use. So we'll provide a link for that information. Let's talk about some recent experiences. So there's been a lot of discussion lately about RN Administered conscious sedation. And this is when there is no anesthesia professional in attendance to administer sedation to the patient. Now, this is being driven largely by the anesthesia crisis. Now, RN Administered conscious sedation has been around for a very long time. Actually, when I got into the industry some 35 years ago, we were doing RN Administered conscious sedation. So certainly not anything new. I think as the years went on, probably it became a little less popular, but now it's back. And that's being driven by the anesthesia crisis. And centers, of course, are looking for alternatives for providing anesthesia. Now, one thing we have to remember when you consider implementing a RN Administered conscious sedation program in your surgery center is the conditions for coverage And the condition for coverage 416.42b, this is the standard for administration of anesthesia, states the following. Anesthetics must be administered by only 1, a qualified anesthesiologist, or 2, a physician qualified to administer anesthesia, a certified registered nurse anesthetist, or CRNA, or an anesthesiologist assistant as defined in section 410.69b of this chapter, or a supervised trainee of an approved educational program. In those cases in which a non-physician administers the anesthesia, unless exempted in accordance with paragraph C of this section, the anesthetist must be under the supervision of the operating physician, and in the case of an anesthetist assistant, under the supervision of an anesthesiologist. Now, I'm not going to read you the whole section there, but what it refers to is the fact that if a CRNA does not have an anesthesiologist supervising them, then a physician needs to be supervising that person unless they are in a state that has been exempted. And I think there's somewhere between 17 and 20 states that do that. And hopefully all of you know whether your state is one of those or not. So here's the problem. When you look at that standard, it appears to state that an RN cannot administer anesthesia. So generally, there has been an interpretation that an RN-administered conscious sedation does not fall within that regulation. However, some states have interpreted it very strictly and do not allow in their state RN-administered conscious sedation at all. So make sure you're aware of what is going on in your state and what the regulations in your state are. Assuming your state does allow registered nurses to administer conscious sedation, then it is important to remember that you're going to need to make sure that the nurses have been granted privileges to administer the sedation and have documentation in their employment files of specific training in this area, as well as ongoing competencies performed specifically for their administration of that conscious sedation. And that competency should be done by preferably an anesthesiologist or somebody that's really a physician who administers anesthesia, though in other situations you could use another very experienced registered nurse to do that competency. Now, the training is available from a number of different organizations, including AORN, and that's probably the one that we recommend the most since we have a very close relationship with AORN. You also need to make sure that the registered nurse in the room is not the circulator also. So, in other words, their only function, that the RN who is providing that conscious sedation's only function in the room is administering the sedation and monitoring the patient. They should have no other duties.
Yeah, and I think a lot of RNs might be a little bit nervous about doing this. I don't know if a lot of us are comfortable with that. I'm sure there are some, so, but just be aware of that as you're making this decision, that the comfort level. Yeah,
very well said, Sue. And actually, I didn't even put that in my notes here, but you're absolutely right, is I think we're seeing a lot of hesitancy. I mean, I know you, for one, would never even consider it. I mean, it's just not something that you were trained for, and even if you did receive the training, I don't think you feel comfortable doing that. And we have a lot of nurses who have been operating room nurses who are very uncomfortable. Sue comes from the pediatric area, but I've yet to find a nurse that's super excited about doing this. And of course, really, if you're going to implement this program, make sure you have some contact with your malpractice insurance carrier, and they're well aware that this is another responsibility that your nurses are taking on. The physician will also have to be granted specific privileges to supervise the conscious sedation nurse. And the standard of care is that supervising physician and the conscious sedation nurse must both have ACLS certification. And that's been a real major problem as physicians have been taking on some of this responsibility, even taking on the responsibility of supervising CRNAs, for example, that they need to have that ACLS certification. So definitely, if you're doing this in your organization, myself as a surveyor, I am going to be looking for the documentation we talked about. I want to see documentation of their training, usually in the form of some type of a certificate from a training program, as well as that ongoing competency, at least annually, perhaps sometimes even more frequently. And be very careful of a small volume situation. In other words, when that conscious sedation nurse is not doing a lot of cases. That's a situation where you might want to do more frequent competencies because your skills can get perhaps a little, I hate to say rusty, but you just are not encountering that experience all the time, and it could be a sign that you might not be providing the highest quality care there. So as we segue into the focus segment, I did want to point out that the Association of perioperative registered nurses, or the ARN, has been a driving force behind a national initiative to address the hazards of surgical smoke plume, focusing on creating smoke-free operating rooms across the United States. And this initiative is rooted in a concern about the well-documented health risks posed by surgical smoke, such as respiratory issues, eye irritation, and the potential long-term effects from exposure to toxic substances like benzene, formaldehyde, and viruses. At the September 2024 New York State ASC Association's annual conference, Penny Smalley gave a presentation entitled Surgical Smoke and How it Impacts You. She spoke to me afterwards about how to take control of the surgical plume, focusing on moving from awareness to action. Let's take a short break, and when we come back, we'll interview Penny Smalley about smoke evacuation. It's been a long day, and the surveyors just left, and you are exhausted. And looking at the list of items that you have to address, you wonder, how can I deal with this and still take care of my patients? More importantly, you wonder, how can I ever keep up with all of the regulations, standards, and accreditation requirements? How can I always be prepared for a survey and reduce my stress levels? Well, that's what Ambulatory Healthcare Strategies does, day in, day out. We become your outsourced regulatory and accreditation resource. We can maintain your policy manual, develop your education programs, help out with fire and disaster drills, do your risk assessments, oversee your quality improvement activities, help run your quality improvement meetings and governing body meetings, and we can even prepare your monthly or quarterly financial statements and help you figure out where you are financially. We are a retainer-based service. We don't take ownership. We don't charge based on your revenue. We have one fixed monthly fee, and we can tailor your services to your exact needs. So whether you're looking for help getting over a survey, preparing for a survey, or looking for a long-term relationship to assist you with your ongoing regulatory and/or financial needs, please give us a call at 585-594-1167 or email us at info@ahstrategies.com. That is info@ah-strategies.com, or visit our website at ah-strategies.com. So I'm at the 2024 New York State Association of Ambulatory Surgery Centers annual conference here in Albany, New York. I'm here with my new friend, Penny Smalley. So many times I interview people I've known for years, but Penny and I have quickly become good friends here. We have a lot in common, and certainly you have so much experience. Penny was here to talk about smoke evacuation, and that's what we'll focus on here. But you'll be back on the podcast, I'm pretty sure, talking about some of the other things. So, Penny, introduce yourself and what you've been doing for the last couple decades.
Thanks so much, John. I'm really happy to be here. I was very pleased with the invitation. And I have not only enjoyed sharing my ideas, but learning from all of the other speakers and the people that have attended this conference. It's been great.
Thank you.
So thank you again to the organization for having me here.
Sure. So what do you do?
I am a self-employed, independent, perioperative nurse consultant.
Okay.
I have been running my business as such since the late 1980s.
Oh, wow. Okay.
And I have worked with most of the medical product companies.
Yeah.
I've done so many different things. My business is basically a potpourri of nursing and medical consultation. I've worked with feasibility studies in industry. I've done a lot of education and training.
Yeah.
My area of expertise and sort of my home nest where I came from is OBGYN and laser technology. That's where it all got started.
Right.
And that's where I was introduced to the risks and hazards of surgical plume, which has been my favorite cause over the many decades.
Well, and our dear friend, Deb Spratt, Deb Spratt, former president of ARN, she and I, actually, I don't know if you knew this, but she and I started a surgery center in 1989, 1990 together. And that's how that was her first surgery center, my first surgery center, and we learned so much together. And we've kept in touch over the years. But this has been one of her passions, especially in her time with ARN. And I know you've worked with her, but this has been a mission of ARN. And, of course, many of the other organizations, state associations, too. And I don't know if you know this, but I helped working with the New York State Association to push through the legislation
here in New York, because we did really feel that it was something to the benefit. Even now, I think some of our centers are a little frustrated with the fact that we pushed this through, because, as I'm sure you're going to talk about, there is misinformation out there, miscommunication, and it's a complex area. One way we certainly can't cover in 15 minutes, but I'm going to force you to kind of do the best you can on that. So tell us, first of all, really a background on this, because not everybody not all of our listeners are actually going to truly understand what it is and how dangerous it is.
Right. So back in the very early 1980s, in fact, our first center where we had lasers introduced us to the need for smoke evacuation, because it was unlike anything else. So the laser companies actually sold or gave smoke evacuation equipment along with every laser that was purchased back then, because they recognized that it didn't smell good.
Yeah.
A lot of it in ambulatory or even in doctors' offices, the patients were gagging and choking and not feeling well. And we knew that it was bad. We had no evidence. We had no research.
Yeah.
We had nothing to prove why it was bad, but we all knew it was. Personally, I had an allergy attack the first time I worked in a room with a laser. And so that sort of helped me to understand that this was a problem. Right. So gradually, the company started sponsoring research studies or quasi-research studies.
Yeah.
And it was sort of ignored by and large by the medical community because it was all commercially biased.
Yeah.
And so, again, there was no really good evidence behind it. And it's gone through a lot of ups and downs and plateaus. But what really helped was in the mid to late 1980s when we started getting public messaging about smoking.
Yeah.
And all of a sudden, everybody understood that smoke was bad for them.
In whatever form.
It was. And so it was equivalent to the backyard barbecue and, everything else that produced smoke. What they didn't understand back then that we do understand now is the fact that it isn't really smoke. That's the problem. The hazard is the plume, which is the diffusion of all this material. So going back just a step, smoke plume, if you want to call it that, is created when you use any energy-based device. So that's a photothermal laser. Not all lasers create plume. All the electrosurgical devices, RF devices, ultrasonic devices, harmonic scalpels, plasma generators, all of these new technologies that create heat is absorbed into the cells, creates an expansion, and finally a disruption of individual cells, which emits all of the material that's in there. So the hazard exists because of the release of all this material that's in the cells.
Yeah.
And that's bacteria and virus and heavy metals, drugs, dyes, whatever happens to be in the cell is now airborne.
The very reason that you took it out in the first place is now you're spreading it out.
And so the risk then is the diffusion of all of that material into the breathing zones of people present in the room, including our patients. So that is really what the hazard is. What multiple hazards are.
Right.
And we're mostly concerned about the transmission of virus, obviously.
Yeah.
The bacteria are larger particles, aerosolized blood and tissue fragments are also a hazard, but not nearly as much as the hazards of HIV and possibly SARS-CoV-2.
So what do we do? What's the solution? Well, let's start with the legislation. Okay. I know you studied the legislation in New York. Just talk in general about the legislative efforts that are going on, because most of the legislation that's showing up in the states are very similar across those states where those occur.
Well, it is to a certain degree, but true. I do want to give a plug for Illinois because that's my home base. I actually, with one of my colleagues, developed a grassroots coalition. We did not use lobbyists. We did not use AORN or any of the other organizations working on this legislation. We wrote letters to the governor, who then sent it to several senators because he's really supportive of health. And after this letter writing campaign, I received a call from our local senator, who said, "This is really interesting. I'll sponsor that bill."
Wow.
And I became familiar with her, and we worked together with her office. My colleague and I wrote all the testimony. We delivered all the testimony at all the committee meetings. And in 9 months, we got a bill passed. And our bill is slightly different because we have a regulatory component, and that's the issue.
Yeah.
When you have a bill, that's the legislation, but it doesn't tell you how to comply with it.
Right.
And so what I've been urging people to do is to contact departments of health or whatever agency has become nominated as the regulatory or compliance arm, and to ask for good criteria for compliance, because otherwise people don't know what to do.
Yeah.
They have a bill, but they don't know how to comply with it.
Well, that's very good. Let me take that a little bit back, because it's so important to understand that like in the case of the regulations that CMS imposes on surgery centers, we have the conditions for coverage, but they don't give you enough detail in that to know how to actually do it. That's where the legislation, where the regulations come in and take it a step further.
And that goes back to what you originally said. There are so many people that are out there, you have a bill, but you don't know basically what to do with it.
What to do with it, yeah.
So it's our job, us being in the fortunate position of being able to reach out to a lot of different healthcare facilities and organizations to get policy, individual policy in each facility. Yeah. And I always tell people this is not a laser policy, it's a standalone policy and procedures that apply to any energy-based device.
Right.
And you can always exceed the law.
Yeah.
You have to meet minimal requirements, which is in the New York law to have and adopt and implement a policy. But the criteria for that policy needs to exceed that statement.
Right.
And so you look to standards to inform your policy. So we tell people to go to the American National Standards Institute.
Yeah.
There is an ISO standard. I'm sure most listeners are familiar with ISO and IEC standards.
Right.
They both have a lot of recommendations. The ISO standard 16571 is the only standard in the world that is specific to plume evacuation, and it sets up all of the specifications for the equipment. So if you're looking at what do I have to buy, or what does my equipment have to look like, that's the standard to look for. Yeah. And then there's an appendix in that standard that has a lot of good talking points that can be used to develop policy. And there are a number of other things like that. But there's resources out there to help you establish the criteria in the facilities that will allow for not just compliance, but in excess of compliance. Good best practice.
So this is a special episode that's for New York State centers. Can you talk a little bit about what that impact has been on New York State, which just implemented? Talk a little bit about quickly about the history.
Well, first of all, it's raised awareness tremendously.
Yeah.
And, we ask for hands up in classes, how many people have this equipment?
Yeah.
Most people do.
Yeah.
The issue becomes, do we use it every day on every case in every room?
Right.
And
does everybody know how to use it too?
No, and that's the gap. So again, looking to the companies for in-servicing, operational in-servicing, but they need the education behind it.
Yeah.
And I think organizations such as this one have an opportunity to develop more and I guess more standardized educational programs that people can utilize. But certainly when they contact the state organizations, because now we have a law, what do we do? Then you have that opportunity to help provide them with some resources behind that.
How difficult is it for a surgery center to really implement this type of a system? If somebody's new to it or is not familiar with it, or know there's a system back there but doesn't know what it does. I mean, that happens a lot. I, as an administrator, I wouldn't know what that is. I would rely upon my nurse manager. But we have a lot of people coming into the industry right now that aren't even from the operating room, like perioperative nurses, that aren't even familiar with all this, that are in leadership positions that are trying to put these things together. So how difficult is it? What resources might be available to them?
That's a really good question.
Yeah.
There are a lot of resources out there. The equipment is simple to use. You don't have to be a nurse to be able to learn you can learn to operate it in about 30
So you're kind of saying that even somebody like me might.
John,
I could.
And in fact, I can show you in 37 seconds how to operate this equipment.
That's interesting.
It's nothing.
Yeah.
So as far as a burden goes, it's not.
Yeah.
As far as financially, you can get evacuation systems depending on what your needs are.
Right.
For $1,000 or for $10,000. The equipment is not heavy capital equipment. It requires consumable contracts because you do have a number of disposable pieces that go with it,
Right.
tubing and filters, etc. But if you first do a baseline risk assessment in your facility, how many procedures do you do with energy-based devices? And then you establish how many cases can you do on a filter, because it's the filters that are the most expensive part.
Yeah.
But that allows you to choose the level of equipment you need. It has to be portable because it will go from one side of the table to the other, and you have to be able to move it around, so it can't be a big footprint in the room, obviously.
Yeah.
There are built-in systems if you're in the process of remodeling or building a new ASC. There are actually central evacuation systems that can be included in the architecture, and it's inside behind the walls. So there's nothing in the room but a tubing. There's everything from these little handheld devices up until that completely central system, and everything in between. So it's easy. There are a lot of companies out there that produce this equipment, but I encourage people, when you start looking at the companies bringing in equipment for trials, it's the ESU pencils that often may be the make or break for a particular piece of equipment. So it's a matter of getting the surgeons involved. If they've used it 5 years ago in another facility, they didn't like it because the equipment was a bit more bulky back then and a bit more uncomfortable to use. So they have a mental image that this is not really something I want. But now the equipment is so much better. There's something for everyone.
Good. So that's a good message out there, is that, and we do recognize that this could be cumbersome in the sense that you're not familiar with the process, but there's a lot of resources that are available to help you get through it.
There certainly are. The standards, the articles that are out there, all they have to do is Google, and you get tons and tons of material. Or you can, contact the companies, and they'll help you out with that.
And just lastly, talking about Google, when you and I, before I actually met you in person, I did a Google search for you, and I was expecting to see all these things about smoke evacuation, and you showed up in research papers and other things like that. So you have been an incredible resource to the industry, and I know you've been around a couple years, like me.
Just a few.
And so just on behalf of a grateful industry, thank you for so much of the hard work. And you're going to be on the podcast again. Probably next time we're going to talk about lasers.
That would be really good.
I was thinking we haven't talked about that on the podcast, so we'll get in touch with you again soon, and probably that's what I'll bring you back next year to talk about at the conference.
I'm ready and willing.
Thank you so much for joining me.
Thanks, John.
In this segment, we provide an update on upcoming topics for the podcast, our upcoming virtual conferences, and upcoming speaking engagements for John and his staff, and other events in the ASC industry.
So the accreditation organizations all have ongoing conferences or regular conferences, and I just wanted to point out that AAHC's next Achieving Accreditation Conference is March 20th through the 21st, 2025 at the Renaissance Orlando at SeaWorld in Orlando, Florida.
And the Joint Commission's Ambulatory Care Conference is November 5th and 6th, 2025 at the Crowne Plaza, Chicago O'Hare in Rosemont, Illinois.
The Georgia and South Carolina ASC Association Semi-Annual Conference and Trade Show is March 20th through 21st, 2025 in Atlanta, Georgia at the Renaissance Atlanta Waverly.
The Florida Society of Ambulatory Surgical Centers Quality and Risk Management Conference is April 10th and 11th, 2025 at the Renaissance Tampa International Plaza Hotel.
ASCA 2025 Conference and Expo is April 30th through May 3rd, 2025 at the Gaylord Rockies Resort and Convention Center in Denver, Colorado. And we, as always, will be there. We'll try to do a couple live recordings from there. And for the first time ever, Ambulatory Healthcare Strategies will actually have a booth. So make sure you stop by and see us.
And the Gulf States Conference is June 11th through the 13th, 2025 at the Ritz-Carlton, New Orleans.
And the Gulf States includes Alabama, Louisiana, and Mississippi. And the Florida Society of Ambulatory Surgical Centers Annual Conference and Trade Show is July 23rd through the 25th, 2025 at the Hilton, Orlando.
The Washington Ambulatory Surgery Center Association's 2025 Annual Education Conference and Trade Show is November 6th and 7th, 2025 at the Tulalip Resort and Spa in Tulalip, Washington.
And don't forget, on-demand versions of the ASC Director of Nursing, the ASC Administrators, and the Business Office Managers bootcamps are available on our sister website at ASC-Central.com. We'll provide a link to that in our show notes. And a reminder for everyone to become a patron member of the podcast. We have over 200 patron members at the present time. Don't miss out on the benefits of joining our patron program available at ASC-Central.com. And this comprehensive membership platform is your go-to resource for all aspects of ASC regulatory and accreditation compliance, operations, and financial management. It's designed with the busy schedules of administrators, nurse managers, and business office managers in mind. And by becoming a member, you gain access to regular Zoom sessions, typically held weekly, and recently they've been on Saturday mornings, where you can engage with other patrons and our podcast team. But that's just the beginning. Your membership unlocks a wide range of resources, including virtual conferences such as the Credentialing Conference and the Conditions for Coverage Conference. You also find valuable tools like sample policies, procedures, forms, and our highly regarded fire and disaster drill kits. Your support of the Patron Program helps us to maintain and grow the podcast, covering essential costs like research, travel, equipment, and production. To learn more and become a member, visit ASC-Central.com.
Thank you for tuning in to this episode of the ASC Podcast with John Goehle. We hope you found the discussion insightful. If you did, please share it with your colleagues in the ASC community. And be sure to subscribe so you never miss an episode. We appreciate your feedback and suggestions for future topics. Reach out anytime at comments@ascpodcast.com.
And a special thank you goes out to our incredible team here, our sound editor, Susan Cronkite, executive producer, John Goehle, and our dedicated research team, Sue Cronkite, Jenna Alvarez, Judy D'Ambrosio, Mike D'Ambrosio, Zach Caloritis, Jim Masters, Amy Cronkite, Lori Rodericks, Kathy Foti, Donna Macchio, and Christina Norman. Your hard work makes this podcast possible. Our theme music is provided by Media Sushi and Mike Noah, and the ASC Podcast with John Goehle is hosted on Podbean and can be found on all major podcast platforms. Thanks for sharing, and we'll see you in the next episode.
This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, RFX Solutions, MedServ, and Ambulatory Healthcare Strategies. Surgical Information Systems provides cutting-edge information solutions for surgery providers. RFX Solutions is your all-in-one healthcare regulatory compliance software. MedServ, which offers the only digital narcotics cabinet specifically designed and priced for surgery centers, helping develop standardized processes and compliance, eliminate paper logs, and prevent drug diversion. And Ambulatory Healthcare Strategies is the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, visit our website at ascpodcast.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.